Welcome to the K in Clarity podcast. I'm the host, Mezue. During this episode, we're joined by Olivier Jarry, CEO and co-founder of LiberaBio. Olivier has been instrumental in developing innovative drug delivery systems within the life sciences space. At his company, LiberaBio, he is leading the development of a new class of precision therapeutics that address previously undruggable intracellular cancer targets. The company's proprietary MPN technology aims to overcome one of the major challenges in oncology, targeting the estimated 75% of disease-related proteins located inside cells that are inaccessible to traditional antibody therapies. Olivier's work at LiberaBio builds upon his extensive experience in the life sciences space, including leadership roles at major pharmaceutical companies such as Novartis, Bayer, and Bristol Myers Squibb. His efforts are focused on leveraging nanotechnology to create breakthrough oncology treatments, potentially offering new hope to cancer patients by expanding the range of targetable disease mechanisms. In today's conversation, we discuss about the complexities and challenges of healthcare reform, emphasizing the mission-driven nature of the industry while highlighting the need for organization and standards in the U.S. healthcare system, as well as the importance of trust in government and the necessity of a patient-centric approach. Also, he touches upon about the evolving landscape of healthcare, focusing on integrated healthcare systems, the role of digital health, and the importance of innovation in patient care. Olivier also addresses a role of education and awareness in empowering patients, the consumerization of healthcare, and the exciting innovations emerging in the pharma sector. He shares pivotal moments from his career that have shaped his perspective and concludes with a hopeful outlook on the future of healthcare. If this is your first time tuning in, here's the gist. The healthcare industry is buzzing with innovations, but there's tons of noise and misconceptions out there. That's where we come in. Because of my experience in the healthcare ecosystem, I've gained a unique vantage point into the industry's inner workings. We're bringing you the conversations that typically happen behind boardrooms and strategy sessions, the real challenges, innovative solutions, and game-changing insights that are reshaping healthcare as we know it. On this podcast, we bring you face-to-face with the industry-leading healthcare founders, executives, and innovators. We're talking about the nitty-gritty of building and scaling healthcare companies, their hurdles they overcome, and the strategies that have led to their success. More importantly, we dive into the personal challenges that come with trying to change a system as complex as U.S. healthcare. So whether you're a healthcare entrepreneur, a medical professional, or just someone passionate about the future of healthcare, this podcast is your backstage pass to the minds shaping the industry. The K in Clarity podcast is proudly supported by Kemora.co, a growth partner firm that works with digital health, telehealth, and healthcare tech companies to overcome growth and operational challenges and drive changes in the U.S. healthcare system. If you're running a telehealth or digital health company and facing growth challenges, check out Kemora.co. They might just be the partner you just need to take your impact to the next level. Now let's have Olivier Jarry tell us a little bit about themselves. Welcome, Olivier. I'm really excited for this conversation to talk about healthcare reform. For the people listening, can you give a little bit of an overview of who you are and what you do as well?
Very good. Yeah, my name is Olivier Jarry, living between Europe and the US. I've been a healthcare executive in very large pharma, Novartis, Bayer, and BMS for a number of years. On different continents, a little bit everywhere actually, and for the last 12 years I've been mostly supporting smaller pharma, currently an executive on 3 different mid-small companies.
I think to start off our conversation, I like to understand where somebody's inspiration or what led them to what they actually wanted to do in healthcare comes from. So if you could have a 1-hour conversation with any, historical figure that has a relation to healthcare, who would it be and why exactly?
I would pick Louis Pasteur. Louis Pasteur, not only because he's French, but was attempting something really new and created the process to immunize people against disease and saved millions of lives afterwards based on this invention, improved by many others after him. But he was really the one to trigger this by his intuition.
I know we had spoke earlier about your extensive history as being an executive. So what actually drew you to the healthcare industry, particularly life sciences and everything that's going on as well?
It's an industry that is extremely mission-driven. Everybody is working for the patient, be it in a hospital, be it in a pharma company. And once you start working for healthcare, you cannot stop. I mean, you realize you can do something for another human being or another million human beings, doesn't matter. But if you can do it, why not do it?
Yeah. With healthcare, it's very mission driven. I felt the same way. That's the reason that I'm, launching this podcast to speak to more people. But right, I think when it comes down to it, we as people that want to innovate in healthcare, right? How can we go about making changes, right, in such a challenging system with a lot of incumbents? Of course, there's people that you may say are greed in the system, as with every, human tendency. But there's a lot of people in healthcare that I know want to do good. I speak to them, pretty much all the time. And so how can that change really come about and being to happen from what you've seen?
Yeah, that's obviously a very complex question. So healthcare has so many pieces, so many. I mean, obviously, the entire payer side, which is very complex in the US, which is simpler in other countries, the entire delivery of care, as we call it, the hospitals, the clinics, the standalone physicians, the nurses, so what we call in the US nurses practitioners, many players, and obviously a huge variety of patients with diverse needs. Honestly, it makes it difficult to just leave it as the market will find a solution for it. Imagine you would do the same for the aerospace industry and say, okay, everybody can fly their plane, that's not an issue, and just take off from your street and that will be fine. So as you know, and I'm referring to aerospace a lot because these were my first degrees, so apologies for that, but it may come several times.
Yeah.
But you see the airplanes have been extremely safe for many years because of organization. Things are organized, things are regulated, there are codes in place. Not everybody can do whatever they want. To certify a plane is an immense amount of work, and things are working really well. Healthcare deserves the same. Healthcare deserves an organization, norms, standards, and some organization by the government in order to make sure that the rules are obeyed and things are not getting chaotic. That's probably one of the complexity in the US, which is it's a free market. It's a very free market. So a lot of things may happen and a lot of people can insert themselves in the system and abuse the system. So the system has become so complex that it's frankly unmanageable, especially left to its own decisions. Reform in the US would have to be extremely deep, would have to really eliminate a number of players, make things more direct, and it will be painful. There will be a lot of resistance. That's another issue of the system, which is the political system here relies a lot on lobbies, and these lobbies will be extremely active and will threaten the politicians to remove their financial support, and that will cause inertia. At this point, there is no other solution really than changing a lot of things. There was a very interesting poster on the floor of the Senate shown, I think, in 2008 by two senators that wanted to show the complexity of Obamacare. It's an interesting poster with like 100 bubbles and 200 arrows showing this is the system now. And that's true. I mean, they were not exaggerating. They didn't like Obamacare, but what they depicted was the reality. And the ACA, known as Obamacare, just added complexity. So added coverage, which is fantastic for millions of people uncovered, but added complexity. And this needs to be solved quite radically.
I think the relationship between care, right, and how that's kind of gone through with the government side, right, and with policymakers and the people that actually want to actually bring about the changes you mentioned. What do you think is the relationship and the dynamic between these two parties, right, that are actually going to help, I don't want to say regulate in a way, but regulate the system to really have an efficiency and effectiveness carried out, as you mentioned, right? And same thing with aerospace, you have, there's certain rules to actually fly a plane. So how do you think change can happen in such a complicated process, as we could say, with many stakeholders involved?
Yeah, that's an important question. One of the issue in many countries and extremely acute in the US is people don't trust the government in general, and they don't trust that it will be that it will bring efficacy and that it will be impartial, and that that it will take care of them, which makes everything difficult. Where people trust the most the government, such as the Nordic countries in Europe, is actually where the healthcare system works the best. And this positive relationship translates in ways that, for example, in Sweden, the individual healthcare records are completely managed by the government. People trust that it's part of the work that government has to do. The government uses the data for very interesting epidemiological studies, understand the health of the general population, how they could intervene to improve global public health in Sweden, and this kind of thing. So this is an extreme positive, I would say, situation where the government is doing well and people support the government. If you look around the world, the US could be almost the opposite. People won't trust the government. The system, the way it is today, penalizes people that are transparent. If you start showing that you have pre-existing conditions, you must be afraid that somebody is going to use it against you, being an employer, being a healthcare payer. So people are very, very careful with their information. The HIPAA regulations are helping, but it makes it difficult for government really to intervene, being a major player. Again, a complex issue, but a few things I may suggest. One is this issue is probably more with federal government than state government, and some state government, like in Vermont, have attempted to create systems that are nicer to patients, essentially, or more efficacious to patients. Some try to do some kind of Medicare for all, at least at the level of the state. So I think we should leave the states or give the opportunity to the states to actually manage themselves, maybe the healthcare of their own constituencies, and they would have more credibility to do so. In general, obviously, it's still not a very simple solution. Second is maybe the government doesn't have to be directly involved in all cases, but could be indirectly involved and helped with some processes or some controls and so on. For example, there are in other systems agencies that verify that there is no abuse of a system. And obviously there are some in the US. The payers have their own, let's say, analytics or algorithms to verify that there is no abuse. But this could be improved as well. Having some kind of design, let's say, process systems. And I know there are very software and there are many solutions, but there is still abuse, so there must be something to improve. Eliminating abuse would be great. And abuse includes just too much treatment. I mean, probably many of us have stories that they ask a question to a doctor and they got a battery of tests, and then they say, okay, no, yes, maybe let me get another opinion. They get to a second doctor who runs the same battery of tests or a different battery of tests. So why pay twice for all these diagnostics? I mean, these are made by machines. They are independent. It's not an opinion. You don't have to do them twice. Why do you need at your dentist a set of x-rays every 6 months? Besides consumption, you may not need all of that. So obviously there will be an opposition by the industry. They won't like that somebody is trying to limit the use of care. And if a patient wants to pay out of pocket, why not? I mean, if they are clearly given the choice, okay, you can pay and get more x-rays, and why not? I don't want to limit liberties, but at the same time, let's not put people in a bind that they have to spend more money. And one pet topic that you and I discussed previously is the single payer process. So I'm not saying a single payer big brother that will be on top of everybody and watching what they do and pointing the fingers, and you shouldn't be doing that. But a system that will eliminate all the complexities today of coding. If you ask doctors, they spend hours in a day, and their assistant, they spend their entire day coding, finding the right codes, sometimes abusing the codes to find a way to get paid for what they are doing. And this is just unacceptable. I mean, every doctor wants to take care of patients, not to take care of codes. And having a system that is more straightforward, the payments are made without considering that there are actually 1,000 insurance systems, at least in the US. I mean, there are the 5 bigs, and there is 100 mid-size insurance, and there is 400 smaller insurance, and there is self-insured. It's just unmanageable. So having a single payer point, I'm not sure if we need another term to call it, but that will really simplify the entire system. That will be fantastic.
Okay. Going off into that system, right, as we discussed, I guess how do business leaders really play a role into that? And who should they go to first? Is it the people that, of course, the doctor is always going to be important, or the person that's providing the care is always going to be important. But who should they go to first to actually bring about a change to simplify a very complex process,
Where do you start is your question in a way.
Yeah, right?
I was told many times, and I'm mostly a big pharma guy, as you heard. I mean, I'm
Yes.
not a doctor, I'm not a healthcare executive or whatever, but I was told always by my management or my lawyers, if you start with a patient, you'll always be right. So if you find ways that you identify the pain points for the patient and how you can eliminate them or make them more acceptable, you'll always be right. So why should a patient have to do complicated things? Why should they ask for prior authorization? Why should they do a number of things themselves? I mean, I was charged at some point for a bill that I believe we didn't deserve from a hospital on the West Coast. It took me about 1 year to solve it. And I had two insurances, actually. And the issue was the two insurances were fighting each other, saying, no, the other guy has to pay. No, the other guy has to pay. And I was in the middle. And I had to kind of, I wouldn't say reconcile them, but at least show them that one of them maybe pays half and the other half, and they should stop just this kind of fighting. And I still lost a few $1,000s in the process compared to if I didn't have to fight. But why would a patient spend hours to save thousands of dollars and have to fight themselves? So we use very often in the pharma industry what we call a patient journey in the US or outside the US, and different diseases from accidents to bleeding to whatever may happen, stroke, and we follow what happens to this patient. They go into an ambulance, the ambulance does this and this and that, and you try to find the points where the system doesn't work. I mean, the person is rushed to the hospital, but then wait 6 hours before being seen by a doctor or this kind of thing. So I think if we can start with a patient, and that would be a simplistic answer to your question, but start with a patient, and that will be a good point to rebuild the system. Just one quick note, actually, maybe also, there are people trying things, obviously, and unfortunately they don't go very far. So years ago, an organization that I won't name tried to bypass PBMs. And PBMs, pharmacy benefit managers, are usually not very much liked in the industry. And many people would want them to, let's say, reduce their influence, to be polite. And this organization tried to bypass them. That was very interesting, and they didn't succeed. Another organization, this is public, Lilly, is selling directly to patients or communicating directly to patients, which is interesting in the industry, quite new for the US, and very interesting. And I wondered why others don't rush to do it. They don't rush because it's not easy, actually. So that would be very interesting to bypass PBMs and pharmacies and whatever, and just people buy their drug this way from the manufacturer. Kurt Cobain obviously has also his own system. So there are parallel systems that are being developed. The savings are just humongous. I mean, they are just, when it works, it's just amazing. And hopefully that's another ray of light of a way to go.
I love that. I think to add to the ray of light, as you mentioned, when it comes down to a lot of patients, right, to people that are day-to-day consumers that we might say in the healthcare system, which I guess patients should be the right consumer that people are targeting as business leaders. But how do you go about going through, especially in the US population, where you might say younger populations, I would say, this is just my own opinion, are probably more inclined to take their health and their fitness more in their hands versus, older populations of health, right? Which might not be as educated in the internal systems of, I would say, even the younger populations as well, but that older population is maybe not as educated on the entire process, what's going on there, right? They give a lot to their doctor in comparison to maybe, a younger population who have done their own online research with accessibility into tools and things. They're probably speaking to their doctor and say, hey, have you ever thought about this? So there's a little bit of a difference within these populations. How do you, I guess, speak to them additionally who are not as educated about what's going on in the internal workings of healthcare and codes and how people get paid, right? That creates a lot of confusion. I know that's kind of a big question, but what are your initial thoughts there?
Yeah, no, there are many pieces inside, but very interesting pieces. So the first one is education. And nobody obviously I'm from the industry, but nobody is educated enough about health. It's so complicated. With my colleagues, we exchange emails every day with I've seen this article, have you seen this new research? They seem to say that this and that. It's not what we thought about. And we keep being educated. As professionals, we keep being educated every day. The patients are way behind. They don't have the time to do what we spend our time doing, but they need more education. And the proliferation of stuff, of noise on social systems, social media, doesn't help. I mean, making your own assessment. People say, oh yeah, no, I can make my own opinion. If you just take it from Facebook, you can make an opinion, but is it going to be a well-informed opinion? Probably not. And especially people don't have a training to do scientific, let's say, review or whatever. So a real education is important. Who is best placed to do it when people don't trust government and don't trust their pharma company? Probably the doctors, probably some maybe some, say, lower-ranking healthcare professionals, nurses. In many countries, nurses are really the one taking care of patients and the one that are trusted by patients. They are not seen as corrupt or pushing a product or this kind of thing. So that would be a good way. We spoke together of low and medium income countries, such as in Latin America or in Africa. You do have actually educators, either paid by the government or paid by NGOs or paid by municipalities that are organizing to actually educate people. I had the chance to do it several times in my life in the Philippines, in India, in Latin America, in Africa, to create these teams that are essentially educators. So they are not dispensing drugs, they are not making diagnostics, but they are educating people. If your neighbor has this kind of cough, if your daughter has this kind of issue, this could be this, so don't neglect it. You should actually see a doctor, and your nearest doctor is Mrs. So-and-so. And just bringing people to be diagnosed and then helping them getting access to their medicine is very important. So education, I'm comparing, and we spoke of Nigeria, I'm comparing Nigeria or Kenya with the US, which some people may say, oh, but we are not the same. In terms of needing education, everybody needs education. So it's a good starting point in your questions. The question of age, yeah, it's more a question of, let's say, openness to try new things. In general, so people who are older, they may say, okay, I went to CVS all my life, or I went to this doctor and unfortunately is retiring, but I trust her a lot. And they prefer not to change too much. Younger people, I see my children, they want to try some of the good RX, purchase of drugs, or some other ways, and they say, oh, Dad, I found I can pay here $50 when the other, if I go to the traditional pharma, I pay $300 for my drugs, so I'm going to go to this one. On that aspect, yes, I think that they know how to look for information, and they are very open to change and to try new things. However, I'll put a caveat in terms of digital and so on. I worked in digital health, especially around diabetes, blood pressure, pain management, with one of the leaders in this segment for a few years. I would say it's amazing to see how older people that have all their capacities, but can actually use a phone and manage their own symptoms and their own treatment and report the right thing to their doctors and so on. It's just amazing. I mean, the apps are designed for all kinds of populations. So even if you have difficulties with your fingers, and they are relatively simple, relatively focused, and people really use them if they are 60, 70, 80 years old.
I think speaking about your experience, right, in pharma, I think a lot of people sometimes they think of pharma as this big, scary thing, right? But as we understand, there's a lot of middlemen involved as well in that process. I think, can you speak about any pivotal moments maybe in your career that you've learned through there that, you think could be helpful to other people in healthcare?
I have a history which is a little bit unconventional because I've been in many countries. Usually people are really good at one country and they know super well the German system or the Spanish system, and I've been in different countries, and what I found is that I come back to it, if you take care of a patient, things will be fine. And when you go to new countries that you don't really know, and you have a task actually to bring medicines in the way that is relevant to these people, then you may need to reimagine the system. So in large pharma, we tend to, in general, to be monolithic, and I'm generalizing, so it's not correct. but which means that we are used to cater to relatively rich and educated physicians in rich countries. So going to less rich countries, we touch 10% of physicians that touch 10% of population. And that's a business, and that's fine. It's just not helping the entire population. So when you go to a broader population, you have to think differently. You have to be compliant, because this is a non-negotiable with any pharma company in the world. But you have to be more creative, and you have to bring education, which is what we just discussed before. Usually we call it awareness. It's very often awareness of the disease and make sure that people understand the disease, awareness by the local doctor that there is a treatment for the disease, which is not necessarily a given. But awareness is where we spend 90% of our time in these countries. And in many cases, we should do the same in rich countries. I don't believe that the ads on TV in the US are really helping. They help a little bit on raising questions, which is good, but they are biased, and they are not providing, let's say, the entire scope of a disease. But awareness is very important. In these countries, the next one that comes to mind is always affordability. Very important. Obviously, you cannot ask for any kind of crazy price, but at the same time, you need to make a profit. I mean, that's part of the system, and if you don't make a profit, you are not going to last in the market. You're not going to help patients. So if you want to help patients, you have to make a profit, even if it is a small profit. You have to make the drugs available, which in many rich countries is not an issue. You can find the drugs anywhere. I mean, although obviously there are huge distances in the US, for example, and you may be far away from a pharmacy, but and people are looking at drones or other ways to deliver. The issue is even more acute in less rich countries. If you are far away from the capital, you have more difficulties. And you can also have drones. Actually, I have colleagues that work on drones to deliver drugs in remote places. And then you have to work on very often adherence. And adherence is a problem with in rich countries, but it's a huge problem in, again, less educated countries. People believe, okay, I've been given 3 pills by the doctor for the next 3 days, I'll be fine. No, you cannot be fine. Either it's treatment for life or treatment for a month that you need to get, and you need to buy more pills and follow what your doctor is saying.
Paired with what you said there, I guess, when was a time that you went against that conventional wisdom that's in the healthcare industry and what you've seen, right? I believe there's a story that we had spoke about a little bit that I think could be interesting in touching on this.
Yeah, totally. So back to access to medicines, and maybe it gives a different light to your viewers. But I was managing a relatively large field force. I would not call it a sales force, because we are not directly selling. We are educating and everything we need, we said in India. And the way to motivate them and to show them what was important for us, it's just in a few words, because everything was going through translation. As you know, English is very spoken in India, but not everywhere. And same thing for Hindi or Marathi, or when they are spoken locally. So it had to be simple. And I used something that I borrowed from a US bank. But the 3 important things for us are our people. So we need to take care of our people. It's our brand and our reputation. So we can do nothing wrong. And our brand was important because it's part of reputation. I mean, it's actually the etymology of the word branding, which is create an image that people trust. And if they see that the doctor, the pharmacist, or by an educator, they are going to trust it. So we developed an image for this program that we called at the time Arogya Parivar, Healthy Family, and people would just recognize the characters and the image, and that was super important. And as I said, we were really educating mostly doctors and the population, and not selling, because my reps were not qualified according to compliance rules to be selling. So when I was explaining this to our bosses, many visionary bosses, this was for Novartis, said, this is great, we get it, that works, fantastic, that's exactly what we want to do. But sometimes I was a bit provoking, and they said, what product are you selling? And the fact is, we were promoting indirectly some drugs, not directly. But I said, I'm not selling products. And people said, oh my God, you are not selling products? But what are you doing? What are we paying you for? Which in pharma, if you are sales and you're not selling product, it's kind of a big paradox.
Yeah. You spoke a lot about, I guess, what motivated you on that side. Is there anything that you're seeing that makes you excited currently about, where things are going in healthcare and pharma that you think is something that, a lot of leaders should actually know and actually maybe implement in their workflow or their day to day, or is there anything that they should be knowledgeable about?
Yeah, there are many things exciting. The first one is some people would call it consumerization of healthcare. I would call it responsibilization of healthcare, making the patient or the person responsible for managing their care. And responsibility is not easy. It's just easier to say, okay, it's not me, my doctor said something, and if I die, it's his fault, it's not my fault. But I think that people realize that they need to take their health in their hands and do something and lose weight. I mean, you see the success of GLP-1 is people realize that there is a benefit of losing weight if you find a solution that can really help you. So I think that's one of the most exciting things of the last 20 years in general, but even more and more with more digital tools and more things that are accessible to the consumer or to the patient. So this is one of the exciting things. Obviously, from the industry, we see a number of exciting discoveries or new treatments. GLP-1 is not really new. GLP-1 has been around for a while, but discovering all the new applications is new, which is good because it seems to have heart protection, kidney protection, brain protection, and a number of other benefits. So that's all of this is good. But there are incredible treatments that are coming up, helped by AI and machine learning and all the things that are fancy. But the reality is, yes, there are new treatments coming up. They are going to be expensive because, unfortunately, the business model of the industry is you have to spend a lot of money in order to bring this to something that patients can safely use. But it's just amazing. I mean, you once, a few years ago or decades ago, you had a few small molecules coming up and a few blockbusters coming up, and they were starting to help with statins and other things. But now there is an explosion which is just unbelievable. So that's great as well. I think that the third thing would be, I think there are more and more disruptors coming up. And I was mentioning these internet pharmacies that propose much lower prices with actual products, real products. I mean, not something doubtful coming from who knows where. And this will help patients a lot as well. The one thing I'm very hopeful with also in the US system is integrated payers providers. And we didn't speak of it, but these are the likes of Kaiser Permanente, Geisinger, Intermountain, and these organizations I had the chance to interface with from the outside, but they are both providers of healthcare and payers, and they are balancing both the monetary aspect and the health of their patients, and usually patients stay much longer with them than regular payers, so prevention has actually a payback for them. For overpayers where patients change their insurance every 2 or 3 years, okay, if this person has diabetes in 5 years, that's not my problem. That would be the next payer. And I'm oversimplifying, obviously. For the integrated payers, if people stay 10 years, 15 years, 20 years with the same payer in the same region, they have an incentive to actually reduce the cost then and educate the patient now, give them some prevention tips and help them have a better life or healthier life right now. And in general, they have a better balance of costs than regular hospitals as well, because they are also the payers at the same time. So if there is a way, for example, to get your hyaluronic acid in your knee instead of having a knee replacement, that's probably what they would be doing. So they have been growing for the last many years in the US to represent now a significant percentage of the healthcare. And I think that's the future of healthcare in the US as well. And this is great. I compare it to the NHS in the UK, for example, which is also a provider and payer, and the same in many European countries.
Okay.
People may say, oh my God, no, NHS is not working. Yeah, NHS has issues, but in principle it's working well. But these provider payers in the US are fantastic.
Okay. And I guess that speaks on the privatization, I guess, a little bit more of it's being more of a governmental system, right? What do you see are the downsides, I guess, to this system. I think you spoke on the benefits, which sound very interesting, right? I'm kind of close to this situation as well, actually. So I think I hear some good things about it, but I think what are the downsides of that system and kind of what you see there and that payer provider?
That's interesting. Actually, honestly, I don't see many downsides. Your point is totally correct, which is because it's managed privately and not publicly, there is an additional incentive for efficacy and really managing things properly. So you're absolutely right. Honestly, I don't see downsides to the point that in many cases, first we integrate local university hospitals, meaning that they have actually innovation, they love innovation, when they have a means to evaluate innovation. So you bring a new device, you bring a new diagnostic, you bring a new antibiotic, which I did, and they have a means to evaluate it in their own hospitals and say, yeah, you told me this was better because this and that. I checked it out, and yes, the outcomes, medical outcomes are better this way. The safety is great, the costs are reduced by that much, and the patient loves it. The quadruple aim. They are almost the only ones in the US really to be able to evaluate it because it's actually very complex. And when we launch a new product, I try to keep my mind open, but very often we just start launching, or at least testing and launching with these integrated provider payers because they are willing to test, willing to learn, and willing then to share the knowledge with others for the benefit of patients.
Okay. Is there any other, I guess, healthcare organizations or people that are providing care that you think are the most likely to bring about innovation and be bold within the system besides these integrated payer and providers?
Yeah, as mentioned, I worked in digital health between 2016 2020, and you cannot do everything at the same time, so now I'm more biotech than digital health. But I had a chance to see a number of very, very interesting players. I was part of DioHealth. I had many interfaces with WellDoc, with Omada. I'm going to forget a number of them. And these are first remarkable organizations with very good products or business models. Omada is more probably in-person coaching. Some others are more digital coaching. But digital health has gone a very long way and is really helping patients change behaviors. They are all based now on a closed loop. Essentially, you measure something or you have a device, you have a watch that measures something, feeds the system and says, okay, in the last 3 months, you've walked your 10,000 steps, let's say, and now your heart rate is more stable or you lost weight or these kind of things. And people have this closed loop that shows them that good behavior, and behavior is a bad term, but let's say good habits, health habits, lead to good outcomes or the opposite and help people improve at a very low cost at the end of the day. So I still have a lot of hope for the expansion and the increased sophistication of these systems.
How do you define digital health? Because I feel like digital health can be very expansive as a term. So how do you kind of define it, and who is digital health really helping the most? Is it the people that are providing the care? Is it the patient? What do you kind of understand?
When I managed Bayer Diabetes in 2009, this was the very beginning of digital health, and we asked McKinsey, BCG, Accenture, Ernst & Young, everybody, 10 companies, 10 consultancies, I think, what is digital health and how can Bayer Diabetes be better at digital health? We got 10 different answers that probably wouldn't apply today anyway.
Yeah.
And it was just a beginning, so that's totally understandable. And the term is still very broad. So anything that is touching health and has some kind of electronic behind or some kind of data behind is digital health. So I will narrow what I said before. And there is a term digital therapeutics, actually, which is really how can you help improve outcomes directly using systems. And these digital therapeutics have actually 3 or 4 industry organizations. The one I love is the Digital Therapeutics Alliance, dtxalliance.org. And the reason I love them, there are many reasons, but one of them is when they started, they edicted 10 rules for any company joining them. And I call them the 10 Commandments, which they never liked, but these rules were essentially bringing these therapeutics at the same level as pharma products. you need to have clinically proven efficacy and facts that you can show to doctors that show that it works, that it's really helping patients. Otherwise, it's just snake oil. And all the companies participating, including the three companies I named and many others, followed the rules. They were providing this evidence, and they provide usually regularly. I mean, they publish new studies. I mean, from Dario, I receive like every 3 months or 6 months a new study that shows the benefit of using the system on 5,000 patients, 10,000 patients. Very interesting studies. So I think it's a good definition, it's a good standard to be at the same level as and interestingly, the way that we measured some of these systems, especially in diabetes, is an efficacy similar to drugs. So we used to say in diabetes, you should aim at reducing hemoglobin A1C by 1%. I mean, it's a very general statement, so it could be challenged, but you have a number of drugs that can reduce by 0.5% up to 1%, and you have a number of digital therapeutics that can reduce by 0.5% to 1%. So they work very similarly, and you can use both, obviously.
Okay. I think with digital health, right, it being so broad as well, what do you think that digital health companies could do to be successful? And I'll put it like this. Usually they're probably going to be working with people that are providing the care, right? Could be this physicians, doctors, people that are involved in that system, and they're targeting them. But usually they have to find a person that's a stakeholder, somebody that can be a champion for their product and solution with these organizations. However, it can be hard to provide that innovation or that reform, as we had mentioned previously. Now, what can they do to, I guess, find these people, but additionally speak and actually bring about their product and change? Because these are cycles that take a long time to implement, and then there's the integration and the workflow that's all involved. And so how can these companies, I guess, really expedite that, but also find the right people to speak to actually bring about that innovation, as you had mentioned a little bit, and that reform?
Yeah. The first aspect is recognizing that even if you put their health in the hands of the patients, they will need doctors. I mean, people that are not 100% healthy will need a doctor. And sharing the information between these devices and what we call the unit of care, the doctors, the nurses, is quite essential. And it's something that early on these systems have neglected, and that has become important, and by natural selection, the ones that survived are the ones that actually make this information easily usable by doctors. It's on your health records. You can upload it to your clinic or to your pharmacy and make it visible. If you choose so, you can obviously keep it confidential for yourself. So this integration of care, of having the same information, which is rich and complex. I mean, if you measure your own blood glucose, it's a lot of data. If you had a continuous glucose monitor, it's a lot of data. Patients often need help actually to interpret it. And if you can integrate the different players around this data, not only the patient, that actually helps a lot. So that's the first thing. With meaning that it's going to change a little bit the flows, the workflows, as you say. So a doctor, instead of saying, show me your paper records of your blood glucose in the last 6 months, will say, okay, show me your machine, or show me a printout of the data, and I will read the data, which is not extremely different in many cases. You find more differences in areas such as surgery, and it's not my segment, but I've been consulting in an orthopedic surgery probably 6 or 7 times, actually probably more, probably 15 times. And it's very, very interesting, because it's obviously very complex, like any surgery, especially when you are getting close to nerves and blood arteries and all kinds of things.
Yeah.
And you need to take into account all kinds of images, what you see really of a patient now with your own eyes, plus x-rays that were done before, plus other kind of images to locate the nerves and everything. And you have to do it in a way that is really going to help the surgeon. And the surgeon essentially says, you can change whatever you want, but I want to keep my eyes, and most often my hands, except with robots, on the patient at all times. I want the information I need right now. So if I need whatever the blood pressure of this patient right now, I need to have a reading very quickly. And I want to save time. I don't want my procedure to be any longer than before, because I'm doing 8 patients a day. I don't want to do 6, I want to do 10. And And I have a few more ones. So you have to listen to a physician in that case. You have to adapt your re-engineering of the entire workflow in order to improve their lives. There was a very good summary of this actually at the Digital Therapeutics Alliance in a meeting in DC many years ago. But somebody said you can disrupt, but you cannot interrupt. And that was actually very deep. I mean, in tech, you disrupt everything.
Yeah.
And the doctor say, I'm perfectly happy you disrupt, but don't interrupt my workflow. I'm doing my thing. The life of my patient is on the table, and don't interrupt me.
How can people make it, or how can these companies make it easy to, I guess, share that information and make workflows not be interrupted? Even disruption, I think some people might be, I don't know if I exactly want that. There's a highly resistant to change, I would say, sometimes in healthcare. But how can it be easy to share information and really integrate workflows? What are some things that you have on that side as well?
Yeah, what has slowed down medicine in general compared to other areas by about 30 years is the complexity of making things digital and sharing complex data. When I was in aerospace in the it was a struggle to move quality controls that were on paper and signed by 6 people on a system, on a tablet, and people would upload on the system and sign on the system. Say, oh my God, can you trust the system? Can you sign on the system? I want to keep a paper, or I want a printout of this. So this was in the 80s. We got to the same level in medicine in the 2010s, if I'm oversimplifying, and many things are behind this way, but it's coming up. And with the improvement of the capacity to manage complex data, unstructured data, what we used to call big data. Nobody speaks of big data anymore because people speak of AI, but big data was and is still that, which is you have an immense amount of data that you try to make sense of, and you have system that starts to manipulate it and make sense of it. And AI is the next level or the next name of it. But that's what people are using now. So I have these 5 images. One is coming from this device, one this over device, one this Siemens system, one this and that. And then I have my real microscope from Olympus, whatever it is. Putting all of this together, you start to need AI that says, yeah, I got it. Let me make it simple for you. This is the nerve. This is the artery, this is the bone, this is the cartilage, and this is where you have to operate. So it's just amazing, actually. It is happening, and all these complex and disparate things are put together and made very simple. If you can make it simple for anybody, including a surgeon, that's a win.
Going back to your prior experience, is there any digital health transformation project that, was really successful that you think leaders can really learn from, that you think could be involved in what they do as well?
Yeah, let me go back to the lower income markets. One of the issues in these markets, like for other markets years before, but is paper records. And when you are in a clinic, sitting in a clinic in one of these countries, and you see patients coming, usually they come with their own records, which is good. At least they have their own papers. It's not stuck somewhere. And they say, doctor, this is my papers. I cannot really read them, but this is the papers I got for the last 5 years. So please, and I feel bad here, and please help me. And obviously you get a flood, you get a fire, you get whatever, and these papers disappear. So there is also a need for digitalization of these records. What can you use? Everybody has a cell phone, which is fantastic. In many of these countries has changed the lives of people to find the price of crop or to find all kind of information that they need to have. And you can use the cell phones to record some of these health information. I have a number of friends that have been in this segment for many years, and this really works, which is great. So people just come up and the information has been stored on the cell phone. Interestingly, in a number of countries, these cell phones are shared between different people. Maybe there is one phone for a family of 5, let's say, and then, okay, whose records is this? And one colleague, this was probably 10 years ago, but said, okay, let's identify the people not by the cell phone like we do in the US, but by either face recognition. At the time, it was iris recognition. So yeah, you can have 5 people in the same household. Once they hold the phone and it recognizes the iris, say, this is whatever, and this is your record.
I guess how would you compare the countries that you've gone through, right? We had mentioned, Nigeria as one. We had mentioned, I believe, Russia as another, couple other countries that you've involved, India as well. How can, I guess, leaders, people that are involved in policy really learn from these systems? And what are these, I guess, people doing well, right? That is different than our own, right? Because I think one thing that, sometimes people have mentioned is, Sweden, all these other Nordic countries, they think you can easily implement what they're doing into a whole nother population and a whole nother society, which is not possible. But what is things that I think you've seen them do successfully that you think could maybe be arouse some interest in some people?
Yeah, these large countries, and what you mentioned are really large countries, including India or Brazil or China, they are very often organized politically in multiple levels. They have a federal level, they have a state level or province level, and then they have a municipality level. And these are dozens of millions of people in some places, even at the lower levels. They tend to a similar model in many cases, and the one I like the most is Brazil, because they tend to be very pragmatic. They don't have a lot of resources. They have to use them in the best possible way for public health. People are usually very dedicated to make it work, even with limited resources, just amazing. And if I continue with Brazil, at least the part that I've been exposed to, at the federal level, you have very complicated things and the very innovative things. So when I say complicated, if they want to go into cell and gene therapy, if they want to go into, if there is a pandemic to address, if there is a catastrophe such as God forbid, a radiation or a huge fire or something major, this is managed at the federal level, and guidelines as well, and usually purchase of basic medicines as well. So they get the best prices. They negotiate for huge quantities of generics at the federal level, and they have a huge purchasing power. At the state level, they do the more ordinary thing, but still a little bit complicated. So most of the hospitals are managed at the state level. The number of things are customized, but you get regular surgery. All of this is done at the state level. And then very interesting, at community level, at municipality level, they usually take care of things where you need more interaction with people. So one of them, for example, is birth control or in general, family planning. And you have advisors at the municipality level, and people can come and ask their questions and get answers or coaching or what do I do? I found I'm pregnant and I want to do this and that. So there is local advice. There is usually mental health at this level because you need also to be close to people, give them feedback, advice, see them, check on them, go to their house to check on them, and these kind of things. I've seen a number of programs also for pure preventive health and preventing diabetes, high blood pressure, also done at the local level, because people know people and they say, oh yeah, this recipe is fantastic, but if you use less sugar or less salt, you get used to it, but it will actually be better for your health because this recipe has a lot of sugar and these kind of things. These three levels could exist the same in the US. They don't for a number of reasons, and the actors in the US are more across states and more complicated.
Yeah.
As I said, I believe the state level could actually be very, very strong and very useful. But in these countries, pragmatically, they do the best they can at these three levels.
Okay. And is there any strategies as well, before we get into the lightning round, that you think can really help people go through the regulatory complexity environment of healthcare and really bring about the change as well?
Yeah. So regulatory, I will make it into two categories. Okay. Regulatory of rich countries, very complicated, changes all the time. You have bulletins explaining the changes, you have consultants explaining the changes. The only way to survive is to hire experts, typically consultants, and they are up to date and they will help you navigate. Just the special treatment, fast track, whatever process in the US, there are like 7 or 8 of them. And I couldn't even cite them because I forget them. They are just too many and too complex. They are great, but they are too complex. So that's for rich countries. It's just super complicated. And you need to follow all the rules, otherwise you get in trouble. For non-rich countries, interestingly, things are usually simpler, more pragmatic. but they have a different level of complexity. The bureaucracy is sometimes heavy, complicated, slow, corrupted, and the only way to survive is to hire experts that know how to deal with it. So in both cases, at the end, you need to hire the local experts,
Yeah.
but for very different reasons.
Now time for the lightning round. So one of the questions I think you have a great take on is, what is the biggest myth in digital health?
Yeah, I will make it in a few words. It's build it and they will come. It's a myth.
Explain that a little bit more. I'm actually interested in that one.
Yeah, when you have so many people, it's less now, but years ago, believe that okay, I'm going to make this new app, and this new app is going to manage this and that, and people are going to love it because it's obvious. My design is fantastic, and my interface is fantastic, and they build the app, and nobody is using it, because obviously for using a health app, you need to have people need to be aware of it. They need to have maybe the doctor recommend it. They need to understand what the app can bring to them. There are so many layers for people before they start using your app. And then second, for them to continue using your app that most people neglect. So you can have a good idea, but building or having somebody using an app for a long time for their health benefit is very difficult.
Okay. What is your biggest prediction in healthcare for the next 12 months?
So single word, disruption.
Okay.
There will certainly be disruption in the US based on what we are hearing so far from the people that will be in the new administration. And disruption in general is good if it doesn't, again, interrupt the entire healthcare system in its track and people don't lose healthcare. But there are many things that need to be changed. So if we want to be positive, let's make sure that the good changes happen and the bad changes don't happen. In the good changes, for example, I've been very attracted. I was in the food industry, and I've been very attracted by rumors about eliminating some additives in the US. And many of these additives are forbidden in Canada or in Europe because they are deemed dangerous. And they've been left in the US for decades, and knowing that they are dangerous, if they can be removed, that would be fantastic. And then there are other ideas that may be less good, and hopefully the science and goodwill and good common sense will prevail.
Going into it as well, what is, I guess, the best advice that you've gotten around healthcare to really bring about that change?
Yeah, and that will close the loop to something in the beginning, which is as long as you take care of the patients and you generate clear benefit for the patients with your innovation, you will be fine. Regulators will be fine. Doctors will like it. Payers will like it because you are doing the right thing.
Olivier, thank you very much for your time, for your insight, extensive background. You cover a lot of industries, you cover a lot of locations, extensive experience in multiple countries. Going with what we've spoken about, right, is really focus on patients, focus on the simplistic aspects. Is there any final words that you have for the audience to really take away with?
Stay healthy.
I love it. Thank you, Olivier. Where can people find you, kind of understand a little bit more about what you do, and going from there?
Other simple thing is LinkedIn, Olivier Jarry, Jarry on LinkedIn.
Okay. Olivier, thank you again. Thank you for your time. And this concludes another K in Clarity podcast.
Thank you very much.